Oh, thank you. Good evening, friends. I'm grateful to have been invited to present this disease. It's a rare disease, but we commonly see it. Now, Blount's disease is also known as tibia vara. And since I'm addressing audience, which include students who are sitting for the exam, our colleagues who are experienced surgeons, each one of us will learn something. I'll also learn from you guys. Now, the objective of today's discussion, one, is to explore the probable basic science. Two, try to decipher the natural history of early and late Blount disease. Three, try to evaluate the pathomechanism of this condition, and also see how the images can contribute to the management of the disease. We shall also look at the main treatment options we have in our country. First, the history of the disease, first described by Philip in 1922, but thereafter Blount discussed some cases in 1937. 1949, Blount, he introduced growth modulation of stainless staples, which the problem was the breaking. Then in 1964, the classification was developed by a large scale. And 1984, Thompson et al. Subcategorized the disease into late, that is the late onset as juvenile and adolescent. In 2000, the figure of 8 plate, for those who have used it, is a common instrument we use while treating this patient, was introduced. And recently, Bogart introduced H plate and also advocates solid screws. Blount's disease, the definition can say, is a developmental dissonant endochondral ossification of posteromedial tibial plateau. In the old terms, Blount's disease is categorized as infantile and adolescent. However, because of the natural history which has been evaluated, the current terms now employed include early onset, that is from 1 year, 0 years to 4 years, and late onset from 4 years up to 10 years. So the juvenile part and the adolescent part are classed together as one disease. For us to appreciate what happens in Blount's disease, there are basic sciences which we need to remember. The first is the KAFO, the changes of the physiological deformities around the knee. In the screen, you can see the Arrhenius curve, which shows how the varus changes, collects 2 and 0 by around 2 years. Now, this is a borrowed graph, but the study done around has indicated that our children tend to delay in this collection by around 6 months or so. The parents may come early because of the physiological deformities, but the following will help you allay the anxiety. The symmetry of the disease, of the deformity, the improvement of the collection, the symmetry of the varus condition. All that tells you this is unlikely to be pathological. However, if there is unilateral deformity, that highly suggests a pathological condition. Bone assessment is also important in our children. Why? Because of the decisions you are going to make. And we use chronological age, secondary characteristics, and the radiological assessment. The radiological assessment we commonly employ is Gulick and Pyle. Now, in Blount's disease, they are a little bit advanced in age, that is their skeletal maturity is a bit advanced by almost 2 years. But this advancement of the disease usually approaches the normal towards the adolescent age group. The normal cartilage has the Lissav zone, proliferative zone, maturation, hypertrophic, and vascular. Why that is important is because the disease itself, the abnormality is in the growth plate. For the varus deformity to form, one, the mechanical theory has been advanced, which has been described by Hutter and Bockerman. The observation is that because of increased pressure, there is reduced multiplication of the cells, the chondrocyte cells. But closer look microscopically, the columns are disordered and there is no ossification. Occasionally, because of this pressure, a bone ledge forms, and that tethers that side of the tibia. That's the posteromedial side of the tibia. And that, of course, prevents the growth and hence the deformity. The result of that is secondary attenuation or thinning of the lateral collateral ligament, which explains the subluxation of the knee as well as the lateral thrust, which is typical of Blount's disease. On MRI, we are able to describe a few changes. One of them is the blood supply to the tibia as well as the femur side. If you look at that slide, you'll find that the green describes the blood supply. But at C, position C, you find that there is irregular supply of the tibia, and of course that will affect the growth of the bone, and hence the development of the deformity. That's why it is defined, sometimes it's referred to as osteochondrosis because of that blood supply disruption. The disease has several characteristics, clinical features. That slide has the characteristics. Then you contrast the early onset and the late onset. In the early onset, not all children are obese. That's my experience for the few children I've seen. But late onset, they're usually obese. A child of 10 years can weigh up to 80 kgs. The race, of course, we are all Africans in Kenya, but I've only seen blacks, I've not seen a white. The sphericality is more in early onset. It's usually bilateral in 50% of the children. In the late onset is only 10%. So late onset, they may present as a unilateral deformity. Female are usually predominant in early onset and male in the late onset. Epiphyseal slope is often higher, that and increase in the early onset compared to the late onset. Other features, of course, which have been evaluated include vitamin D levels have been studied, but there haven't been any difference in the finding. The proximal tibia varus, high in magnitude in early onset. However, in the late onset, the varus deformity around the knee is also contributed by the distal femur. Hence, when you are treating these children, many a times you may turn your attention to the distal femur. Procavitum is more prominent in the early onset, and the only way to appreciate this is examining the child from the side. We have seen these children have an advanced age, bone skeletal age, unlike the normal children. Internal tibial torsion is more prominent in the early onset and less prominent in the late onset. That brings us to the how do we make the diagnosis. First, the diagnosis can be clinical as well as radiological. We should appreciate that Blount's disease is very difficult to distinguish from the physiological bowing. However, by closer monitoring of these children, either clinically, we advise the parents to look at the improvement, subjective improvement of the deformity. And also, many a times I advise them to try and observe the intercondylar distance. The tripping of these children also decreases as they play. That is an evidence that the varus deformity is improving. Then you look at the metaphyseal beak as one of the typical features we look at. And just below the metaphyseal beak is the sclerosis of acute angulation as well as sclerosis of the cortex below the metaphyseal beak. Internal tibial torsion, that one you encephalate by looking at the foot progression angle as well as the foot thigh angle, which we shall visit while looking at the physical examination. The leg length discrepancy is usually observed if a patient has a unilateral deformity. You have seen majority have bilateral deformities. History is important in these children, the age of onset, particularly if the onset is early, that's 0 to 4 years, it has a different natural history. Those who present late from about 4 to 10 years, the natural history is different, and the treatment approach is a little bit different also. Weight increase, you have said most of these children, particularly early, have high BMI, so it's good to look at that also. Early walking has been said to be a risk factor in the development of Blount's disease. Tripping, of course, because of unstable knee, they tend to fall many times as they play with other children, particularly the young ones. Knee pain is appreciated in the late onset because of the strain allowed the joint as well as cartilaginous changes. The recurrence, of course, the child may come because of recurrence, particularly the few I've operated have come to me because of recurrence of the deformity, which is common if the onset is early, unlike the late onset. The family history, it has been observed in the family. Here in Kenya, a few days ago, we have identified a family, 2 brothers who have the disease process. Physical examination, of course, because of the students who may be sitting for the exam, is you look at the stature of the child. Because skeletal dysplasia is one of the differential diagnoses of this condition. And by looking at the stature and the symmetry of the body, you may be able to tell whether this patient is having a normal skeletal growth or a defective skeletal growth. BMI is important. 1, as a risk factor, and 2, it influences the option of the treatment you may choose in the collection of the deformity. Limb length discrepancy. Remember, even if the patient has bilateral Blount's disease, the growth may not be symmetrical, and that difference in the varus deformity leads to limb length discrepancy. Procurvatum, which you observe from the lateral side when you examine the child from the lateral side. The gait is also important, but what is crucial in the gait observation is the lateral thrust at the knee joint. That highly suggests the Blount's disease. Foot progression angle because of the tibial torsion, but these children could also be having increased femur neck version that may lead to in-toeing. Laterality is important, but old scars, of course, will suggest previous surgery. And that, of course, will influence what you may need, how you may decide to handle these children. There is that sign, the stiffer cut sign, which suggests the instability of the knee when the vagus stress test is done at 20 degrees of friction. It's highly suggestive of Blount's disease. Hip version, you evaluate it clinically using the trochanteric prominence, although there are other radiological methods of assessing the neck version of the femur. The foot-thigh angle is also important because you are trying to assess the tibial torsion, and that will influence whatever collections in axial planes you'll make. After your physical examination, of course, we lead ourselves to the differential diagnosis. First and foremost is physiological, varus deformity, which improves with the time. Nutritional rickets, of course, is there, but to be evidence, other physical signs will be noticeable in these children. X-linked hypophosphatemia will present with bowing. Skeletal dysplasia may also present with bilateral bowing, but the symmetry of the skeleton development will suggest otherwise. Focal fibrous cartilage dysplasia is usually unilateral, and the deformity is many a times below the pes acellina. That's how we tend to distinguish focal cartilage dysplasia from Blount's disease. After the differential diagnosis, we need to confirm our Blount's disease, and the best way, of course, relied on is X-ray. The shortcoming of an X-ray is difficulty in distinguishing stage 1 and 2 from the physiological varus. And this many a times are children who are less than 2 years. On the X-ray, you may be able to get to observe several things, which we shall discuss down. Musculoskeletal ultrasound is useful in assessing the tibial torsion, and also you can use it to assess the neck version. Arthrogram, of course, is necessary, 1, to assess the regularity of the joint, and 2, it will show you the dynamic instability, and 3, it will guide you in the insertion of the screws. MRI for 3D, the cartilage slope is more important. It's more useful in the surgery planning than the metaphysical bar. The blood workup usually is because these children are obese and they may have diabetes as well as other metabolic abnormalities. X-ray, what are the importance finding on the X-ray? The Drenan's angle over 16 is always suggestive of Blount's disease. Less than 9 degrees, many of them resolve. And it's 5%, about 5% positive, a predictive value. The metaphysical slope should be able to, that surrender is showing the metaphysical slope. Other angles which you may need to assess to plan your surgery include the lateral distal femoral angle, as well as the medial proximal tibial angle. The joint orientation lines are important when you are trying to elevate. The technique I use of elevation, the middle plateau. It's also good to note the mechanical axis deviation so that you can plan how much you are going to collect. Procavatum, of course, from the lateral side, and then mechanical tibial femoral angle will also guide you on the sphericity as well as how much collection and the probable complication you expect. Blount's disease has several classifications. What we commonly use is large field classification, which just shows the progression of the disease. But others like Difflans, Fort Difflans classification as well as LIVIA are useful in surgery planning. What is the goal of treatment? One is to align the deformity. Number two, collect the mechanical axis as well as joint orientation angles. And that, of course, will improve the function of that joint. The options we have to collect this include the guided growth, 2, acute correction, and 3, gradual correction. The pre-op evaluation of these children is very important. One, for those who have very high BMI, they are at risk at anesthesia as well as risk in operation. Bone age is very important. Obesity, night snoring because of the obesity will affect your anesthesia. Hypoxia may lead to pulmonary hypertension, and that's a risk of anesthesia. Right ventricular failure, metabolic and endocrine problems, you may encounter them in these children. Locally, limb length discrepancy is what the noting, soft tissue status for those who have undergone surgery, as well as the developmental disorders you may encounter, like laxity of the lateral collateral ligament. Rotational deformities, both contributed by the femur as well as the tibia, are worth noting. Because of their BMI is high, these are children who are at risk of also of getting skiffle. So examining the hip of the child is important. After you have examined and concluded on the diagnosis, then you turn your attention to the treatment summary, treatment of these children. What treatment plan do we have? First, we have said stage 1 may spontaneously resolve in the majority of these children. So you can just observe by noting the intercondyle distance, doing X-rays at every 6 months. Why every 6 months? You expect some improvement of 0.5 degrees per month. So by end of 6 months, you'll have at least, you'll notice a 3-degree improvement. The second option is KAFO, the hedged KAFO. It has exponential shortcoming, which we shall discuss. Then osteotomies, both of the tibia, fibula, intra-articular osteotomy or hemi-plateaued elevation, which I commonly use. The surgery of the facial bar. Remember, in the pathology, we are ruled that a facial bar or a bone bar will develop. And that means excision if you are to allow to promote the growth of the posteromedial side. KAFO. The problem with KAFO is, up to now, we have no good evidence of its usefulness. One, the children who are obese, the children who are bilateral, the older children, they usually are uncomfortable in KAFO. The other problem is, of course, the splint of the collection force. Remember, the coupling of the KAFO to the bone is usually a challenge. But it has been noticed that an effective pressure of 20 kilopascals will affect the growth of, the division of the chondrocyte cells. This treatment, if it is gone for, it has to last for at least 2 years, but the outcome is usually very poor. The schedule for it is 23 hours in a day for quite some time. You do it for at least 4 years when you expect the development to have either resolved. Osteotomies, which is the gold standard of stage 4 to stage 6. The principles include, of course, the MAP, that's an eponym, sorry, comprehensive physical examination, as you have said, deformity planning on good quality X-rays, and these X-rays are from the hip all the way to the ankle. And then choose either you're going for acute or growth control for stage 1 or 2. Then growth Gradual control, not growth control. Gradual control for stage 1 and 2 is usually indicated for the very obese children, because you can be able to fine-tune your collection. The MAP is a term which is summarizing what you should do. First is to assess, do the malalignment test. The second one is you analyze the joint orientation lines. Pick the bone which has a problem. For the adolescent, the late onset, the femur can contribute to the varus deformity area, so that's the tibia. So if both of them are contributing, then you have to handle both of them. You identify the apex of the collection, because if you do your osteotomy at that, the apex usually presents the center of rotation axis, and that will help you do the collection in axial, sagittal, as well as colonal planes. If the cut is below that, then there are other maneuvers you have to do, the translation. So the bony cut choice, where to do the bony cut, is also important. And the collection you have to do. Acute option, osteotomy options will include acute. I know various osteotomies have been described, but Gordon has not found any difference in the outcome, whichever the osteotomy you do. So as a surgeon, you can choose which you are comfortable with, like I've chosen the hemi-plateau osteotomy, elevation osteotomy. The straight ones, the tibial hemi-plateau elevation, that's the common ones I do. And then the focal dome. The fixation method will depend, 1, on the materials you have, 2, the sphericity of the deformity, and 3, of course, the economic status, status of the patient, because some of the materials can be very expensive. Let's try to look at the treatment as per stages. Stage 4 is defined as the watershed stage. After that is usually surgery. Before that, stage 1 you can observe. Stage 2 and 3 you can do straight osteotomy and either cast it with a K-wire, fix it with a K-wire and then casting. Stages 4, 5, and 6, various osteotomies are devised to collect the deformities. So stage 2 and 3, proximal tibia osteotomy is devised. Remember, when you are doing the osteotomy, you must spare the tibio-timbalostea in these children. Otherwise, you precipitate a genu decabatum. Stage 4 and to 6, that's the challenging. That slide depicts commonly what I usually do. For the mild ones from stage 4 to 6, simple growth modulation or permanent fusion of the growth plate through the femista technique will allow the collection. The lateral epiphysiodesis, of course, will slow down the growth of the tibia. People now think that it's easier to deal with limb length discrepancies than the deformities themselves, more so if it's recurrent. Note that, as you said, you choose the bone, in that percent of the patients, femur contributes to the varus. And if the femur varus is beyond by 5 degrees, that is from 80-something to around 95, then you have to do distal femur osteotomy and deplating, and that helps collect the varus deformity in the two bones, The fixation techniques, of course, will include circular, that is Elizalov or hexapond. Sometimes you can use K-wires, depending on the patient's financial status. After doing that, of course, the osteotomy, particular elevation, use the fibular strut to maintain your elevation. You can see at that diagram, there is a fibula which is stuck between the elevated proximal epiphysis and the diaphysis. Other surgical osteotomies to correct your deformities, of course, the femur. And the femur, not only the distal femur, the proximal femur, sometimes you may go for it if there is excessive anteversion, more so if it is more than 26 degrees, because that will cause persistent in-towing of the patient. One child I have managed is I did my usual hemi-plateau elevation and then a tibia osteotomy, but the foot was still in-towing, so I had to do a supramalleolar osteotomy and a short casting. The tethered physio bar, you can also handle it to try and improve the growth on the medial side. This is a challenging surgery, one, because of the instrumentation, and two, if the size of the physio bar will influence whether it will work or not. Rather than doing that, you can do a figure of 8 on either side, the fast and growing side. Treatment principles of delayed Blount's disease. Those are patients who come late, maybe 10 years. They are usually obese. You can do simple lateral epiphysiodesis. The outcome is usually said to be good in those with BMI less than 40 kgs, and also those with weight less than 100 kgs, and also those who have varus less than 15 degrees. Those we can go for simple growth modulation. Occasionally, osteotomies, you have to do gradual correction with the hexapond and circular flames, as we have said, for these delayed Blount's conditions. Medial hemichondrodastasis. The problem with that technique is, of course, the pins may go through the joint, and if they get infected, you precipitate septic arthritis. So it's not a commonly performed procedure. Distal femur derotation osteotomy, you have said it contributes to the varus deformity, and you may go for the tibia. My local data, after discussing what is there in the literature, for the last 2 years, I reviewed my records in my clinic, and I found 113 children. The findings includes the youngest is about 1.5 years, and the oldest was 16 years. The BMI, just like other literature, is high in all of them. Majority are bilateral, and more males than females in my records. Treatment options I've given these children. One is osteotomy plus casting for those who are stage 1 and 2. And then growth modulation, figure of 8. That's the common implant we have around. Although you can use low profile 3.5 plates. Double osteotomy. This double osteotomy is a misnomer, but it includes hemi-plateau elevation and tibial diaphysis osteotomy and the plating. Now that's an example of one case, 5 years, who presented to us with very severe genu varus. The first stage I did a figure of 8, and then you can see the transition from the early figure of 8 insertion to the second X-ray, which has shown some collection. This child, I removed this figure of 8 plate last week. Unfortunately, the child developed a fracture while playing with others, but I just managed it non-operatively in a cast. The image of this child is there with well-collected deformity. The second case is a late onset, 13 years, was joining Form 1, and he was very anxious after his class 8 exam. So he came to me because of recurrency, and we went in and did hemi-plateau elevation, fixed with a plate. And then lateral, I did a distal osteotomy and did a lateral plate. And the outcome, as you have seen, you can see his photo standing at his father's door before the surgery and a photo after the surgery. I did one side in December. After 4 weeks, I did the other side. And then around the child only to walk to be mobile on a wheelchair before he joined the secondary school. Adulthood Blount disease. I've seen a few patients who comes with a very severe varus, deformity of the legs, and arthritis. Most of this will go for total knee replacement, but because of the deformity, you may also be forced to do osteotomies of these knees. The current research which is there is single-stage surgical treatment. What is this? You do hemi-plateau elevation, osteotomy, and then do a complete epiphysiodesis on the lateral side. In my practice, I've not been doing lateral epiphysiodesis of the tibia on the lateral side, but I've not seen any recurrence of the deformity or significant recurrence of the deformity. But people are now going for this in hoping that if the patient develops recurrence, then, shortening, then the people lengthening will be easier. Summary of the treatment. This is a bimodal disease. Early onset has challenges of recurrence. Late onset, as you have seen, most of them are obese. Femur contributes 30% of the deformity. Stage 4, as we said, is a watershed stage. Osteotomy recommended by age 4. This osteotomy, you can just do casting. Then growth plate modulation after age 4 is to help collect your deformity or prevent recurrence. The basic principles of deformity has to be that are followed closely. Goal is to restore the normal biomechanics of the knee joint. Fixation method is also key. And osteotomy geometry makes less. Osteotomy fixation and osteotomy geometry makes very little difference. So you can choose which osteotomy you would like to be doing and fine-tune your procedure. At the end of it all, what has the patient gained? 1, self-esteem. The boy I operated while going to school was very anxious. 2, efficiency of the gait. We say that the young children triple and can sustain other injuries. And then energy expenditure is better and the child become latent. Those are the 4 things you achieve as another point for these children. I finished my talk at that point. Thank you very much.
Thank you, Dr. Gakuya, for the presentation. I'm sure you can read the questions. Are you getting me, Dr. Gakuya?
Yes, I'm getting you. Where are the questions?
They're usually on the chat.
It's me. I'm still analog.
Are you IT proficient?
No.
Irene, identify the questions for Dr. Gakuya.
Dr. Gakuya, you're able to tap on the chat on your taskbar?
The chat?
Yes.
Okay, I've seen it, yeah.
Yeah, the questions are outlined there.
The questions are here. Let me see where to start. From Joseph, acute corrections are there any empirical guide for the rate of correction to expect from figure of 8? Yeah. 1, the figure of 8, the outcome is not very predictable. That's very something to note. But normally, what I've seen is the tibia may collect at 1.2 degrees per month. So usually by 16 months, you may have, by 1.5 years, you may have collected your deformity. But in general, the epiphysiodesis is not very predictable. The other questions, thank you for the advantage of osteotomy. Yes, fasciotomy, particularly if you do double osteotomy, I usually do anterior compartment fasciotomy 2 as a prophylactic against compartment syndrome. Thank you very much. Yes, Dr. Asif, I think we have cooperated with you. Pelis, thank you very much. Thanks, Dr. Gakuya, Hemend. That's the end of the questions. I can't see any more.
There are many.
Hello? There are many.
Yes.
Oh.
Any advantage in fasciotomy and the use of C-arm?
Sorry, C-arm. Yeah,
Any
when I work,
advantage in fasciotomy and the use of C-arm?
yes, fasciotomy is advantageous because to prevent compartment syndrome. The C-arm, if you have an area where you have no C-arm, one, remember the pathology includes hypertrophy of the meniscus, 2, non-ossified cartilage. So even if you use a C-arm, you'll only be able to appreciate the metaphysics. So what I normally do, if I don't have a C-arm, I use a thin K wire, pass it in front of the joint, and collect my elevation to horizontalize that wire. And that one has given me good results. So C-arm may be necessary, but occasionally for myself, I usually don't use a C-arm. For those who have it, they can utilize it very well. Another question, Kelozo?
What is the latest age that you do epiphysiodesis?
The latest age,
Hello.
usually latest age of epiphysiodesis is by 3 years I do epiphysiodesis. That's the latest. That's the oldest children I do epiphysiodesis. When the stage 4, the bar is already formed, you may have to do epiphysiodesis as well as osteotomy. Otherwise, epiphysiodesis may not collect it. So in a nutshell, by 4 years. Another question?
When they are bilateral, do you attend to both at the same time?
No, because of the surgical stress, and also I want the child to, and the pain issue, I only do it serially. I do one side, then after that, I do the second side. The only child I've done in a very close schedule is the boy who was going to the secondary school within 4 weeks.
Okay. Anybody else's question which has not been answered?
Do you have objective guidance for defining how much varus object? Yeah, that one, the big question is if you have bilateral tibia, varus deformity, you can only use your science, the center of the hip, center of the knee, and the ankle joint to align, but you try to give it of a collection of 5 to 10 degrees. That's the varus collection you can do. The rotation also you overdo it up to 10 to 15 degrees, the rotation of the tibia to correct the tibia torsion. Figure of 8, can you use figure of 8?
How long do you keep the figure of 8 plates?
Immediately they collect, like that child, immediately they collect, within 2 years, I remove the figure of 8. The other observation I've made is when you keep them for long, they change their orientation. And when you put the knee at 90 degrees, this figure of 8, you project the axis, they make a very nice V. The other trick I've seen is when you are removing them is a challenge for the obese children. You may find yourself in the joint. Use a small needle to palpate your figure of 8 plate and go for it exactly where it is lying because of the change of orientation.
Okay.
Another question?
Any tips for dealing with the lateral collateral laxity, especially for patients who have acute corrections?
Normally after if you are doing lateral collection, acute collection, the instability tends to improve drastically. I've never tried to do anything on the lateral collateral ligament attenuation or laxity. Another question, Kilonzo?
I'm just reading on the screen.
Yes, lead.
If implants are not affordable, what do you suggest?
If they're not affordable for the stage 1, 2, 3, do a SIBO osteotomy, distort the tibia tuberosity, and do a casting.
Okay. What about complete tibia fibula osteotomies that can also correct rotation in Langenskilled 4+ cases without permanent internal rotation?
One, why the fibula osteotomy will allow you to collect the tibial deformity. So in my practice, the first thing I do is excise as portion of the tibia between the proximal band and the distal band and the middle band. Why between? Because if you go too proximal, you may injure the common peroneal nerve. If you go too distal also, between some people have done osteotomies between the middle and the distal, which is also safe. But the problem is if you encroach on the ankle joint, you may precipitate instability of distal tibia joint syndesmosis. Yes, Kilonzo, another one?
From Mitei, have you personally used the KAFO? Should we discourage our patients considering its poor outcome?
I've not used the KAFO.
Okay. But it has poor outcome, so you should discourage it from use.
Yeah, particularly even in children who are obese, children who are old, and children who are bilateral. If you use KAFO, it's like treating the parents, not yourself, not the patient.
Okay. I'm not seeing any other questions on the screen. Okay, there is, what's your experience with using corrective devices like Taylor spatial frame or Elizarov?
Elizarov, yes, but the others, they are expensive. They are not in our country. The only one I have in my office is SU Flame, which I've not used on children. But Elizarov, I've used it, as well as now Figure of 8 seems to be my favorite, and then the double osteotomy with the plating.
And of course, Elizarov is it really disrupts life for children. Anything similar will be more welcome.
Certainly, yes, I agree.